Thank you very much, Felix. Welcome, everybody. I'd like to thank the Congress for inviting me to give this presentation. Over the last year or so, there's been an exponential increase in publications and data relating to laboratory practice and the new oral anticoagulants or oral direct inhibitors. And in fact, there's a lot of new data at this conference. So I see my role this morning as simply giving a headline overview from a clinical perspective. And in order to do that, I did a Medline search up to March 2013 of this year, and I've really just selected illustrative data which helps sort of flesh out these headline points. So I apologise to those many authors whose work I've not included or referenced this morning. So these are my conflicts of interest. I've received honoraria for sitting on advisory boards from those pharmaceutical companies. Boehringer have supported my attendance at this meeting. So traditionally, anticoagulant therapy involves either substrate depletion, as we see with the vitamin K antagonists, or enzyme inhibition, usually, well, to date, with an indirect inhibitor such as heparin activating antithrombin. And this just shows heparin-activated antithrombin with a reactive center loop modelled into the enzyme. And I put this up because it was about 20 years ago that, in a sense, we were in a similar situation. Clinicians were beginning to move from unfractionated to low molecular weight heparin, and of course, they'd been used to monitoring. In fact, it was necessary to monitor unfractionated heparin. And now here was a treatment that didn't require monitoring or dose adjustment. And for a while, at least, some clinicians were resistant to the idea that treatment didn't need to be monitored and that doses didn't need to be adjusted. But now we know, of course, that for the vast majority of patients, it's possible to treat them with low molecular weight heparin without any monitoring or dose adjustment. And so here we have now the oral direct inhibitors, the new oral anticoagulants, and the situation is the same. We're now in a transition from using oral vitamin K antagonists, which absolutely require monitoring and dose adjustment, to using new drugs where it's suggested, and in fact the clinical trials show, that it's not necessary to monitor or dose adjust. And again, there's an indication that some clinicians seem slightly reluctant to this concept. Now, if we think about the ideal properties, or the properties of an ideal anticoagulant, I've just listed some here. So, drugs that are easy to use, safe and effective from the first dose, a broad therapeutic window, no need for dose adjustment, no need for monitoring, and ease of use regardless of diet or potentially other drugs. And ultimately, what we would want from an anticoagulant or an antithrombotic drug is one where the antithrombotic effect is dissociated from the bleeding effect. And indeed, if such a drug were to exist, we wouldn't need to monitor or measure at all. And so the question is, are these new oral anticoagulants genuine anticoagulants which are associated with bleeding, or is the bleeding risk so low that monitoring or measuring would never be required? And I think you'll probably anticipate the answer to that question when I show the answer in a moment. So the new oral anticoagulant drugs, and I've listed 3 here, and for the purposes of the rest of this presentation, I've simply chosen Dabigatran as an example of a thrombin inhibitor and rivaroxaban as an example of a 10A inhibitor. And in fact, these drugs do fulfill many of the properties of an ideal anticoagulant drug. And they're certainly more convenient. Well, how much better are they? Well, I think they're definitely going to be better because they make clinical practice easier. It makes it easier for patients, it makes it easier for clinicians. And of course, for the vast majority of patients, monitoring is not going to be required, so that makes it easier for the laboratory. Having said that, as you will see, when measurement is required, the requirement for laboratory expertise is going to be even greater than it has been in the past. Now, will we ever need to measure these drugs? I think the answer is yes, we will. The answer's in the name. They are anticoagulant drugs. And if you look at the bleeding rates, and I've just taken, for example, the atrial fibrillation studies here, with the bleeding rates on VKA warfarin and the bleeding rates on the new drug, you can see that whilst they're slightly lower, there is still a significant risk of bleeding. So these were the annualized major bleeding rates in those 3 trials. So if a patient is taking one of these drugs as an antithrombotic, there is going to be a significant anticoagulant effect, and that will result in bleeding. Now, one area that's going to be much easier, I think, is interruption of therapy and bridging. So these drugs have a very predictable pharmacodynamic effect. There's a very fast on rate and a relatively fast off rate. And so interruption of therapy is going to be much easier. So if we consider traditional bridging, it's usually necessary if anticoagulation has to be stopped, to stop this 5 days, for example, before a procedure. Arguably, patients then need introduction of an alternative anticoagulant, which, if it's unfractionated heparin, will require monitoring and dose adjustment. And following the procedure, when the VKA is reintroduced, it's necessary to monitor the INR at least every other day until an adequate anticoagulant effect is achieved. And whilst that's happening, it's necessary to bridge with heparin. Now, with the new oral anticoagulants for a patient established on treatment, these can be stopped very close to the surgery. Surgery can be performed, and the drug can be introduced easily, much sooner after surgery possibly than we see with conventional therapy. And of course, no monitoring or dose adjustment is necessary throughout this process. Now, the drugs are excreted by the kidney, variably depending on the drug. And so there may be instances in relation to renal function when there may be accumulation of drug, or it's necessary to know whether a patient is anticoagulated or not. And whilst the number of drug interactions is much less than with vitamin K antagonists, there are certain drugs, and these are just some examples, where there may be concerns. So, for example, I recently treated a patient who was on a number of anticonvulsant drugs which can interfere potentially with the pharmacokinetics and hence dynamics, and in that situation, measurement and dose adjustment did appear to be quite helpful. So the question is, when to measure an anticoagulant effect? Well, these are some examples, and these examples are included in the SSC recommendation, which I'll refer to again later on. So certainly before surgery or an invasive procedure when a patient has taken the drug in the previous 24 hours, or longer if there's impaired renal function and the drug may have accumulated. Obviously, when a patient is bleeding, if a patient's taken an overdose, when a patient actually develops renal failure whilst on one of these drugs. And it's been suggested it might be useful to measure the effect of the drug when a patient has suffered from thromboembolic events whilst on treatment. Now, personally, I see that that's going to be a difficult problem. One of the advantages of the vitamin K antagonists, of course, is that the INR remains prolonged for quite a long time after the drug is stopped. So you can measure the INR maybe 48 hours or so after a thromboembolic event, and that will be a relatively good indication of the intensity of anticoagulation at the time, or the perceived time, of the event. And therefore it's possible to judge whether the event was due to subtherapeutic anticoagulation or a failure of therapeutic anticoagulation. And I really don't think that's going to be applicable with the new drugs because of the short half-life. The opportunity to do a measurement after the event, which reflects what was going on at the time of the event, is going to be near impossible in the majority of patients in most situations. Now, when the anticoagulant effect of one of these drugs is measured, it's going to be really important to interpret that in relation to which drug is being taken, and we're going to see an increasing number of drugs available to clinicians and patients in the coming years. It's going to be important to relate it to the dose, when the dose was last taken, the anticipated half-life of that specific drug, and factors influencing pharmacokinetics of that specific drug. So clinicians are going to have to be aware of the differences between different classes of drugs and different drugs within the same class. Now, I think one of the really big challenges is going to be education of non-experts. So I think most clinicians are aware of the effect of drugs such as warfarin and unfractionated heparin on routine coagulation tests such as the prothrombin time and the activated partial thromboplastin time. And most clinicians are aware, of course, that the APTT is much less sensitive to 10A inhibition than it is to thrombin inhibition, as we see with low molecular weight heparins compared to unfractionated heparin. The problem with education is going to be the education of all those clinical staff who are not involved in the prescription or management of patients on anticoagulants per se, but who will come across increasingly patients who are on these drugs. So in the emergency room, for example. And I'm aware that many clinicians who are not involved in hemostasis and thrombosis, many of them are not aware that these drugs actually have any effect on coagulation tests. And if they are aware, they're not aware of the differences in terms of the performance of reagents and tests compared to warfarin and heparin. So I think there's an enormous educational role on the part of professionals such as ourselves in the education of clinicians and clinical staff who are not actually involved in the prescription of these drugs. Now, is there a case for monitoring as opposed to measurement in specific scenarios? And I apologise, this should read patients who would have been excluded from clinical trials. So, not unreasonably, one might think that those patients who were not included in the trials and therefore for whom we cannot apply the trial data may sit outside conventional practice, and in those patients some monitoring and dose adjustment might be required. So extremes of body weight, patients with severe renal failure, and I'm certainly using these drugs now in patients with severe renal failure. For example, patients with warfarin-induced skin necrosis with atrial fibrillation who've got severe renal impairment and need antithrombotic therapy. And patients who take drugs known to affect pharmacokinetics, and I gave the example of anticonvulsant therapy. I think the difficulty is knowing actually what to do. So one can measure the effect, but if we look at patients in the trials, and I'm going to come on to this in a moment, there was a significant variation in the anticoagulant effect as measured by a laboratory test. And so the difficulty is knowing whether what we should be simply doing is aiming for the midpoint of an anticoagulant test result. And of course we don't have any data on that yet, and it's going to be important that such data becomes available possibly through registries and through cohort reports. I think an even more contentious area is the concept of trying to optimise individual patient outcomes rather than simply accept the cohort outcomes in the clinical trials. So it has been suggested in the literature that, of course, one sees a variable anticoagulant effect in different patients all taking the same dose, and therefore one might be able to actually improve the outcome from an individual by tailoring therapy for their own individual needs, and therefore by monitoring the dose and adjusting the dose to aim for this optimum level, whatever that level is. And I would personally strongly discourage such practice, because we've got no idea what would happen to the benefit-risk ratio in that patient if we start moving doses away from the doses that have been tried and tested and shown to be effective in clinical trials. Now, the SSC, Subcommittee on Control of Anticoagulation, has produced a recommendation and recognises that some tests will be semi-quantitative. These are the readily available, easily performed tests, which might indicate at any moment in time whether a patient is subtherapeutic, therapeutic or supratherapeutic in terms of the anticoagulant effect. And alternatively, there'll be quantitative tests which can be used to measure the drug level. And I'd just like to share two simple scenarios in relation to the use of the semi-quantitative tests and illustrate this need again for education of non-expert healthcare staff. So I'm aware of a cardiothoracic centre in the UK who recently cancelled a cardioversion for a patient with atrial fibrillation on Dabigatran because the INR was 1.3. And so they thought the patient wasn't adequately anticoagulated. I'm aware of a patient in another hospital who 4 days after a hip fracture was still waiting to go for urgent surgery on Dabigatran because the thrombin time was still slightly prolonged. So I think this illustrates that whilst most patients won't require monitoring, when we get into measurement of the effect, there's a lot of room for bad practice. Now, I just want to point out some headline issues regarding the effect of these drugs on tests. So what we have here is an example study, and in the top graph we've got the prothrombin time in relation to the 10A inhibitor rivaroxaban using a number of different thromboplastins. And if I just bring your attention to the two graphs below, so these are the prothrombin time ratios and these are the ratios of the APTT, you can see that the PT, where the ratios go from 0.5 to 4.5 compared to the APTT ratios, the PT is more sensitive than the APTT to a 10A inhibitor. And that's probably predictable. But what we see is a considerable variation in the sensitivity of different thromboplastins to different reagents. And that's probably predictable. But what we see is a considerable variation in the sensitivity of different thromboplastins to different reagents. And that's why the SSC made the recommendation that each laboratory must be aware of the operating characteristics of the reagents and the tests that they use in their laboratory in order to interpret correctly the results of testing on patients on oral direct inhibitors. Now, this can be done relatively easily, and I suggest that there's one of three ways for laboratories to do this. For laboratories with a particular interest in hemostasis, the easiest way is simply to calibrate their own PT and APTT, having determined the drug level on the plasma sample in their own lab using a quantitative assay. And I'll show you a very simple example of how Roger Luddington and my colleagues in Cambridge are doing this. The alternative for those laboratories that don't have or don't want to have the possibly slightly more sophisticated quantitative assays, they could measure the PT and APTT on their patients and then send an aliquot of the plasma to a reference laboratory where they could perform a quantitative assay and report the drug level back to the peripheral laboratory, who could then calibrate their own local PT and APTT. And a third way to do this would be to use actual calibrants, but there are potential problems with calibrants, and it would be essential to ensure that those calibrants are fit for purpose in that context. So here's a simple way of doing it. So these are just a number of plasma samples that we've taken from patients. We've measured the rivaroxaban level using a calibrated anti-10A assay and then used that to calibrate the prothrombin time in our laboratory. So as you can see, in our laboratory, if a patient has a prothrombin time of less than 13 seconds, then it's not likely, on these limited numbers I accept, that they're going to have a therapeutic concentration of rivaroxaban. And in our laboratory, you can see that the APTT reagent test that we use would be totally unsuitable for this purpose. The same is true of the quantitative tests, and caution is required here. So this just shows the response of two anti-10A assays measuring rivaroxaban levels. And this was an interesting exercise undertaken by Job Harenberg and colleagues on behalf of the SSC, and they distributed 3 samples of known rivaroxaban concentrations. And whilst the average results are very close to the actual results, you can see that there was tremendous variation. On the sample where the level was 100 nanograms per mil, the different laboratories measured between 0 and 600. For the top one at 750, between 400 and 2,500. So I think this illustrates the absolute requirement for robust external quality assurance for those laboratories which proceed to undertake quantitative determination of drug levels. There are many other assays, and I'm not going to go through them all. In the symposium book, I've indicated a table which summarises the effect of the thrombin and the 10A inhibitors on various laboratory tests. This is just an example of thrombin generation, which is obviously very popular at the moment. You can see a clear dose response between rivaroxaban level and thrombin generating potential. I don't know yet how this information would be useful to me as a clinician. And increasingly important is going to be point of care or near-patient testing, particularly in the operating centres, particularly where there's decentralised anticoagulant services. And I put this up just to show that it would be feasible to use point of care instruments to determine the anticoagulant effect of a drug, but we still need a lot more data, and here, as much as anywhere, the necessity for internal quality control and external quality assurance is going to be absolutely key to the correct interpretation. When we move into a thrombin inhibitor such as Dabigatran, predictably, the APTT is going to be more sensitive than it's going to be for a 10A inhibitor, and here we see the typical curvilinear response of the APTT to the Dabigatran concentration. But once again, you see there's a significant variation in the sensitivity of reagents, again stressing the need for laboratories to be aware of how their own APTT responds to Dabigatran or, in the future, other thrombin inhibitors. And this data has been presented by Steve Kitchen from NOACs already at this Congress on Monday, and it just shows this considerable variation between reagents, and these were the reagents used by more than 10 centres, and as you can see at a Dabigatran concentration, the APTT ratio can be anything from less than 2 to greater than 2.5. Now, in terms of quantifying a thrombin inhibitor, it's evident that the thrombin time is clearly too sensitive, and I described the patient who was still waiting for surgery 4 days after stopping Dabigatran with normal renal function. It was interesting in that patient that when I inquired, the laboratory was using an APTT reagent which was quite sensitive to Dabigatran, and in fact the APTT had normalised within 36 hours of stopping the Dabigatran. And so my advice was to take the patient to theatre, which happened, and the surgery was performed without any bleeding. However, if we dilute the plasma to produce a dilute plasma thrombin time, this is an extremely good way of quantifying a thrombin inhibitor. And probably, as you all know, the hemoclot assay has now been calibrated and validated for this purpose. Thrombin generation is much more complex with the thrombin inhibitor. And paradoxically, at low thrombin inhibitor concentrations, there's an actual increase in the thrombin generation as measured by the usual or most commonly performed calibrated automated thrombography. And I don't want to spend too much time on this because, as with the rivaroxaban example, I'm not quite sure yet how this information would help me as a clinician. Kuhn-Hemker and colleagues have demonstrated that this is at least in part an artifact due to the algorithm used in the calculation of thrombin generation, and on this graph you can just see the actual amount of thrombin measured in an experiment, and that calculated from the composite of the thrombin and the alpha-2 macroglobulin thrombin curves in the CAT assay using the algorithm, which clearly overestimates the true thrombin generation. But as I say, I'm not really sure how helpful this information is going to be yet. Just before summarising, it's important to mention the effect of these drugs on assays. Now, I do question why anybody would want to, say, perform antithrombin or protein C measurements while somebody's on an oral direct inhibitor, why people would want to measure a factor assay, why not just stop the drug and wait 24 hours or so and then measure it. But it is important to be aware that there is interference. So with low thrombin concentration fibrinogen reagents at high Dabigatran concentrations, the fibrinogen level is underestimated. And this is just more data from the NOACs study, which confirms data previously published in single laboratories of this effect. Now, the manufacturers of these reagents are now well aware of this problem. And so, for example, IL and Siemens have alternative reagents with a high thrombin concentration, which, as you can see from here, do not underestimate the fibrinogen level, even in the presence of Dabigatran. But clearly, laboratories need to be aware of this. And similarly, if you perform a factor assay on somebody with an inhibitor, just as with a factor VIII inhibitor, there'll be a false low measurement of whichever factor you measure. This is going to be the same with the oral direct inhibitors. And if you look at the PTT-derived assays with Dabigatran, one would predict that those factors measured in an APTT assay are going to be affected more than in a PT assay, and with a 10A inhibitor, the reverse is going to be true. But as you can see, that with increasing drug concentration, all the factor levels appear to be low when in fact they're not. This is just the effect of an inhibitor. So we can consider the qualitative assays which are going to be readily available and give an idea of whether a patient is anticoagulated or not. Is it safe for a patient to go to theatre without delay? Is bleeding due to over-anticoagulation, etc.? It's important that laboratories absolutely are aware of how their reagents and tests perform in relation to the specific drugs. For those laboratories who are going to perform quantitative assays, it's essential that they engage in robust external quality assurance schemes. And in the book, as I say, I've indicated a table which indicates the effects of a thrombin inhibitor and a 10A inhibitor on a variety of tests. And the last thing I'd just like to finish with is the issue of reversal, if we can use that term, of the new ODIs. Now, there will be antidotes in the future. These are not currently available for routine practice, but clinicians in extreme circumstances are using prothrombin complex concentrates, recombinant factor 7A. I think the message at the moment is very simple. One might see an effect of a reversal agent on a laboratory test, but there is absolutely no indication as yet that that correction of a laboratory test would correlate with a clinical benefit. There have been a number of studies looking at the bleeding effects due to the new drugs and the effect of reversal agents such as PCC, FIBA, recombinant 7A, but for obvious reasons we don't really have any strong clinical data yet on how effective these agents are, and as yet we have no idea which laboratory test would be a useful surrogate marker for a clinically effective correction of anticoagulation. So I'd like to finish by thanking my colleagues in Cambridge, my colleagues in the laboratory involved in these measurements, my colleague who runs the anticoagulant service, and my friends and colleagues who put together the SSC recommendation that was published this year. Thank you.